Good afternoon, everyone. Thank you so much for sticking with us for day 2 and the last session of the ONC Tech Forum, our first ever virtual event. We appreciate all of your patience and participation, and I'm just so excited to be able to moderate the session with a all-star lineup to end today. So my name is Ryan Argentieri. I'm the Deputy Director for the Office of Technology at ONC. Just a few housekeeping items I wanted to cover before we jump in. One, if you are kind of still navigating the platform, you can expand. We'll be showing some slides. There is a link in I think it's the top left. I'm not sure, but there is a way for you to blow up your slides so that you can preserve your eyesight. Two, I want to remind everyone, since this is the end of our event, that you can pull in resources into your briefcase, and you will want to check your briefcase because there is some really great content there that is made available to you after the event. And for this topic, interoperability to support care, community information exchange and referrals, there are two exhibitors that I want to direct everyone to. One is Direct Trust, and the other is the 360X program. Both are really vital to this conversation, and there are great resources in both of those locations. Also, ONC's efforts to the 360X initiative that's ongoing for many years is available on healthit.gov. And I will also make a plug for the Cures Act Final Rule website, really great fact sheets, webinars, a whole host of resources. I'm sure folks have questions, are very eager to dig into more of the content that ONC's made available. Our team has worked really hard the last few months to answer questions and provide the most up-to-date information possible. So I will just encourage everyone to go to those spots and stay in touch with ONC. And with that, without further ado, I want to introduce our panelists for today's session. First is, I'll go in alphabetical order maybe, Grace Chen, who is co-founder and CEO of Lucid Act Health. Grace has a successful career as a data architect working both at Sutter Health and Stanford, and working on high-profile care transformation efforts. I would say most recently, and Grace can talk about this, add to this with over 10,000 cancer patients at Stanford Cancer Center, and has a really incredible platform. I'm just really honored and thrilled that she's able to join us today. Then Kina Fong, another CEO and co-founder of Elation Health, the largest network for independent primary care in the U.S. Elation Health is currently serving 14,000 clinicians and 7 million patients since it was started in, I think, 2010. Again, anyone can feel free to correct me with anything that I miss. Kina has a really great personal story as to how she came to found this business. So I'll ask her to talk more about that. But she also has a degree in mathematics and computer science, and a PhD in health and economics from Stanford. And so just, I think, brings a really valuable perspective from across health IT, but also some of the important underpinnings with respect to data considerations. And last but not least, we have Dr. Erin Holvey, who is director of the DC Department of Healthcare Finance, DHCF, for those who don't know, the Healthcare Reform and Innovation Administration. And Erin also is an expert in health policy, health services research, equally passionate about health system transformation, and just brings to this conversation and also to the work she does day in and day out, a great example of what's working in interoperability with respect to the intersection of payers, providers, patients, brings a wonderful insight into the health information exchange community, and also pairs her real life implementation experience with academic underpinnings, which I know I personally have benefited from in my previous life prior to coming to ONC. And just really, again, have some all-stars here. I'll say it again, it bears repeating. And I'm going to kick it off by asking Kina to start and offer some lessons and best practices of what's working at Elation Health. So Kina, over to you.
Awesome. Thanks so much for the kind intro, Ryan. Let me forward along to the the slides to start it off. So my name is Kina. I'm Kina Fong. I'm the CEO and co-founder of Elation Health. As Ryan mentioned, we're really focused on primary care practices, building an integrated network across the country, really connected by our technology platform that includes EHR, patient engagement, panel management. And our goal is really to help primary care thrive in a changing healthcare landscape. And so in this kind of short introductory presentation, I'm hoping to share with you all more about what we do at Elation and also the perspective we're coming from in this discussion on the very important topic of interoperability. So primary care, the slides. Okay. Slides are, I hope that the primary care kind of slide is on the screen now. It was jumping around a little bit. Good. Okay. So primary care. So primary care really is the hub of care coordination in the community, especially for, the 20% of chronically ill that drive 80% of spend. And primary care is really a key driver of information exchange and data exchange. And really in an ideal world, it helps curate and identify what is most important, what needs action from across the care continuum, as a quarterback or as a partner with the patient. And it's, in the very key position primary care holds, it influences 90% of downstream healthcare costs. So decisions like, which medication should I take? Do we get that? Do we take that procedure? Do we go to the hospital, urgent care, ER? Which specialist should we see? Should you even see one? These are sets of decisions and costs that are influenced by primary care. And that stat comes from the Primary Care Collaborative's primary care analysis. And primary care has also been shown to drive tremendous ROI. I mean, there's a whole host of studies across this, but I think one really notable stat comes from the Oregon PCMH program, which showed that $1 spent on primary care saves $13 in downstream costs. So there's really a big opportunity here. And really, as you break down how primary care drives this impact and what a vast majority of primary care team does for a patient, it's coordinating that care. And so as we move deeper into the digital age, the question shows up, how do we make sure they get the information they need, that it's right at their fingertips when they need it, and that when they come to decide or identify they need some information, it's not then a scramble to get it, but rather it's available at their fingertips. So, primary care, Ryan alluded a little bit to my personal experience with primary care and how we started the company. So primary care is really important to me, as I grew up in a primary care physician's practice, and that's really how we started Elation in the first place. So my dad's a primary care doc, and I helped run his primary care practice for a decade, starting from a pretty young age. And I think what I really took from that is seeing frontline how powerful the relationships are in community primary care, how personalized that care is, how strong the trust is, and a result, how effective the care can be. Because, going back to the theme, care can only be as effective as the information that's provided, within that care relationship. And so that relationship's incredibly important. So we really built Elation to preserve that kind of personalized, community-based care, while providing these practices the powerful benefits of easy-to-use, care-focused technology that really lets them deliver the best experience for the patient. So, that message, fortunately, has resonated with practices across the country. As Ryan mentioned, we have the honor to serve practices across the country, about 7 million patients under care, and 14,000 clinicians really across the gamut. And so, when you think about interoperability and impact on care, one thing I really wanted to highlight is the importance of talking about trust. So when a healthcare provider is thinking about, when they see data that comes in from elsewhere, really their number one question is, okay, is this accurate? Is this up to date? Can I depend on this? And they also want to know that this data will be available for them at the right time. Like, is the connection live? Will I know when it's down? If I see nothing, is it because nothing came, or is it because something's wrong? And so once that trust is broken, it's extremely difficult to rebuild. And providers don't really have a lot of time to waste to troubleshoot and figure out whether things are working or not. And unfortunately, it's our current state of our healthcare system that leaves them pretty little extra time to consider anything other than what's absolutely top of mind for their patients or their practice. So, as I mentioned a little bit earlier, one of the biggest jobs of a primary care practice is coordinating care for their patients. And at Elation, that's really been a core tenet of how we've built the platform from the ground up. So collaboration with a patient's care team and whoever's caring for the patient, including the patient and their own caretakers, is really built natively into Elation from the start. And it's actually a really interesting place to be from in terms of an EHR, because, a lot of EHR is currently stuck in the world of still like what happens within the four walls of a practice. How do you, document effectively? How do you write a prescription? How do you write an order? And a lot of that, we get stuck there because a lot of that technology isn't really built to be friendly to the clinical needs of providers. And so, the innovation really isn't driving far past that. But we're in a unique position where we've been able to innovate there, really get a lot of satisfaction from physicians in terms of ease of use of doing the kind of usual blocking and tackling that happens within the four walls of the practice. And we very quickly see that after you do that, the demands are, okay, then how do we connect outside the four walls of the practice, which is really getting to the topics of what we're talking about today. And if you do that effectively within the EHR and really get the information to the point of care, integrated into what already exists as a workflow of healthcare providers, that's really powerful. So, number of things we've done to help deliver on this vision. I think one core part of it is really having a modern open API that customers can leverage to connect to third-party systems to get the data they need and really eliminate redundant data entry and workflows. But I think even more important than that, which is like getting the data transferred across the pipe, it's really important to think deeply about what happens to that data once it comes across the pipe, right? How do we present it in the right way? How do we make sure it's easily found, that it's actionable? And most importantly, going back to the theme I mentioned on the previous slide, how do we make sure doctors trust the information and therefore use it? And experience that's been seared into my memory is having a doctor show me in their large hospital system how the administration declared an integration complete, but the only way the doctor would be able to find the data is to scroll through an enormous miscellaneous tab where the only identifying information without clicking to see more details is the timestamp. And so that's a really clear example of how just getting the data across the pipe is one thing, and then it's like, how is this going to be used? So, with what we're seeing today, we're definitely headed in the right direction by making the reasonable exchange of patient data really a requirement and not an option. And especially for a platform like ours, where we're focused on primary care, exchanging information is really one of the most important capabilities we provide. And we have experience, and maybe the right word is scars, connecting with a whole variety of different data sources. And it's really a jungle out there, things that you might perceive as standardized are not standardized. It's amazing how many ways one can do the exact same thing. But with the ONC Cures Act, the CMS Interoperability Patient Access Final Rule, we're really headed in the right direction. But still, there's so much to do. And with the COVID-19 pandemic, it's clear how much this innovation needs to work within primary care and the front lines. And unfortunately, oftentimes, and partially because our healthcare system is so complex, and just the pure notions of exchanging data, just from a technical perspective, are so overwhelming. I think it's really important that we continue to keep in mind what happens when the rubber meets the road, and to keep in mind the stakeholder to be considered, which is actually the patients and providers on the ground every day. And I hope that in this discussion today, I can really represent that perspective. And I know a lot of you in this audience and in this session have the ability to carry that mindset of the last mile, and what happens to the actual encounter between a provider and a patient, and really want to encourage every one of you to do so. And so with that, thanks for inviting me to be here with you today. Really excited for the discussion, and looking forward to ways we can bring primary care providers in as an active voice for successful data exchange, interoperability, and ultimately a great healthcare experience for patients.
Awesome. Thank you so much, Kina. That was perfect. Grace, I think you're up next. If you can pull down your slides, and also just anything I didn't cover in my introduction. I know you also have a clinician's perspective and an interesting story. So I know we'd all love to hear whatever you wanted to share on that front.
Sure, thank you so much. Can you see my screen over here?
Yeah, we can see you. You just have to go to the slides, and you're good to go. Ready.
Hi. Thank you so much, Ryan. My name is Grace. I'm the CEO of LucidAct Health. So just like Kina, the reason I started this company is also from the experience of taking care of my father. My father is not a doctor, and he actually is one of those high frequent flyers, expensive patient in and out of the hospital. So I really went through the post-acute care health system by taking care of him. So LucidAct is actually an early stage company in the San Francisco Bay Area. We are, using AI to aggregate the data from remote patient monitoring devices data, as well as EHRs, and to reduce the burdens of the care teams. So now, as you know, with the great progression in interoperability, on the receiving end, the providers actually got a tsunami of data. And, when we talk about remote patient care, there are just so many devices to choose from. And there is so much data besides the EHR data. Now they have device data, their patient satisfaction data, all coming at them. And for the care team, is really too little time to read through all the charts and react to the device data. There are a lot of liabilities issue. So that's kind of where I'm looking at from the other side, from the nurses and the provider side. It's hard to find the right hardware, home hardware devices, and that is easy for patients to use. And it's hard to integrate those data into their existing EHRs. Most importantly, the nurses and care coordinators, they already have their current workload. How can they launch a new program and engage the patients correctly, ultimately reduce unnecessary hospitalization? So those are all the kind of real challenges facing the care team in this kind of care delivery transformation from in the office care to more of a remote virtual care. So I'm really proud that LucidAct has made a lot of tractions in this field, especially last year. We developed literally a cloud-based integration platform that we can connect different remote patient monitoring devices and connect with the distributed care team. Today, the nurses, coaches, physicians, they can be, they won't be in the same place anymore. They can be all over the country. And then the devices, there are just every remote patient monitoring device came in with their own apps or with their own data stream. It's really hard to choose which one is good. And then the providers, they don't have a choice to kind of pick different ones. How to connect all these data with patient at home. So Lucidac is basically a virtual platform over here. Not only we can stream the data automatically from the devices, we also have e-visit, telemedicine features and functions. Most importantly, we can bring those data into providers' EHR. I'll tell you a little bit more how we use the care quality HIE to do that. And then most importantly, the physicians and nurses are busy. We have 2 AI-powered bots to help them automate workflows. We automatically create different patient lists based on different roles of the users, so they can focus on the patients who needs their help at that time. We also have a coding billing bot that can automatically put a CPT codes and the billing codes for the care team, so they don't have to hire additional people to do that. Most importantly, after getting all those data, we have social determinants of health analytics to really help save the physicians or nurses time from reading through all those charts. We tag the patients based on their social determinants of characteristics. How it works, we send the patients a home kit with devices and a gateway box to patient's home. Once the patient is activated, their data will be automatically streamed over to Lucidac Cloud. We will send the notifications and engage the care team when the data is out of range, or our algorithm will identify high-risk patients. Then the care team can start a virtual care session with the patients. The very important part of our devices, there are just so many devices to choose from. We realize there are, especially for Medicare, Medicaid patients, they're not very tech savvy. They don't want to, download an app and then pair the app with the devices with all that work while they have chronic conditions. So our device, we don't require the patients to even have a smartphone. They can be living in a rural area, maybe not it doesn't even have Wi-Fi. Our device will work with them. And because we ship a gateway box that have 4G chips in there that can automatically talk with all the peripherals and send data to Lucidac. On the provider side, they use our care coordination platform. We're not just pushing all those data to them. Again, we have the workflow engine behind the scene. We can curate the patient's list for them, and we actually show them which patients during the past 7 days who has taken vitals, taken measurement, who didn't. So give them a glimpse of compliance of the patient from home. This is very important in terms of social determinants of health. Now we got all the data integrated from EHRs, from the devices. We actually use machine learning to index the patients based on 22 different social determinants of health risk factors. We can see, based on their EHR data, whether they have they're taking more than 7 medications. Do they have one of the top chronic conditions? What's their mental health, help from home? All those information are available now from the EHRs. And then when our nurses talk with the patients, they follow a specific symptom checker questionnaires. So we got all that data. The key thing is how to, it's hard for a human to read through all that in a short period of time and understand the patient's high needs. So we use technology to highlight that. So how we got those data, we are part of the Care Quality and Commonwealth Health Alliance. They're, I think that HIE is one of the best things happened in the past 5 years in the interoperability project progression. Now we suddenly have access to 90% of the big EHRs in our country. Like Epic, Cerner, we can get patients 360-degree health history into LucidAct through the standard FHIR API. From here, we actually massage the data into, combined with our device data, we massage it into FHIR protocol-ready data that we can share with different physicians out. So with this, we have been launching this remote patient monitoring virtual care since last year. And from the patient side, we have seen great compliance and patient engagement. Our enrollment rate is between 7 to 80%. And we have seen physicians, helping patients just manage their medications on the phone and reduce patients' ED visit from 1 to 2 times per month to once every 6 months. So from the health system part, we help like Zia Healthcare to manage their billing process from 3 days in the past and to 2 hours, because they just can get all the logs from our system and just push into their EMR for billing. So we have seen great progress. So this is remote patient monitoring and virtual care. It's in a new area. If you want to learn more about that, please feel free to contact me or contact us through this. These are my information. Thank you so much for your time.
Thanks, Grace. That was great. I've got my question. We get to discussion. I just want to make sure that Erin is with us and able to.
Just for a sound check, Ryan.
Oh, perfect. 1, 2, 3
okay.
testing.
Great.
And can you get to grab the slides? Are you good with the? Okay, perfect.
I'm all set. Thank you very much.
All right, take it away.
Okay. Thank you so much. Well, again, Ryan, I appreciate the introduction, and it was really terrific to hear about all the amazing work that Kina and Grace are doing. I'm going to take a little bit of a step back and talk about some of the ways that from a policymaker and a health services researcher perspective, I'm trying to really leverage all the tools at our disposal to really achieve interoperability. And so I'm going to cover the ways that we're attempting to align policy and technology to ensure effective transitions of care. And I'm going to give you a very specific active example that we're working on in DC Medicaid that also has implications, broader implications for our entire community. So before I do that, I just want to take a little bit of an opportunity to make sure folks understand why DC is such an interesting place to be doing work around building a learning health system. And so the first thing I want to emphasize is that we really have the second lowest uninsured rate in the country, second only to Massachusetts. This is due to a very early Medicaid expansion. And so when you think about what we can learn from the District of Columbia, it's really important to note that because of that expansion, DC Medicaid is the single largest payer in the district, and we cover 4 out of 10 residents overall, but 7 out of 10 children in DC. So when you think about, again, what we're going to learn from our experiences addressing prevention, as Kina talked about, and working particularly with our primary care system, there are just tremendous opportunities to demonstrate what we can do with interoperable data and try to really make sure that we're leveraging the high quality care we have in Medicaid to ensure those kids have the best shot at healthy outcomes and wellness over their life expectancy. And that's super important because life expectancy is highly variable in the district at present. we see a 17-year difference in lifespan between 2 wards in the city. And you can keep in mind that the District of Columbia is only 10 square miles. So that's huge variation in a very small area. And we know that some of that is driven really by a lot of avoidable and preventable conditions, which also impacts cost of care. So we have the 12th highest 911 call volume in the country, and we have a very high rate of ambulatory care sensitive conditions. So what we believe, right, the working hypothesis is that if we can improve information exchange across the entire community, since most of our providers do participate in Medicaid, that we can do a good job ensuring that all of those members that I just mentioned get the best care possible. Now, here's the other piece of this with it's more of a tech-focused or health IT focused component, which is that we have very high rates of technology adoption within the district, which is terrific. However, there's no dominant EMR or EHR suggesting that health information exchange is going to be, and the kind of data integration that the 2 prior speakers talked about is really going to be critical to addressing and resolving the current challenges that we hear patients have connecting with their providers, ensuring provider communication and referral to other providers can happen electronically and reduce the very significant reliance on paper trails as well as faxing. And there are actually some notable examples if you want some fun listening or reading. There are a couple of articles by Sarah Cliff and the folks at Vox Media, and more recently in her role in the New York Times, talking about just how much of a challenge this is for district providers in particular. And then, of course, and as I just mentioned, reducing payers and providers spend chasing all of that information down with fax and phone. So what we're trying to do is really think about how to build the kinds of capabilities that were discussed for our providers and for our beneficiaries at scale. And so with support from initially ONC and in combination and partnership with the Centers for Medicare and Medicaid, we're building out 6 major capabilities, and we refer to them specifically as core capabilities for our providers to ensure they have the information that's essential to be successful under practice transformation, value-based care, and improving quality and outcomes. So the first of those is a clinical patient lookup function. As I'll talk about in a little bit, our primary partner within the District of Columbia for Health Information Exchange is our designated Health Information Exchange, the Chesapeake Regional Information System for our patients, or CRISP. And so they have a really excellent patient matching algorithm, and we're actively working on not only on some of those issues, but also some of the simple and secure digital communication that's needed among providers, as well as advanced analytics for population health management, combined with some of the electronic clinical quality measure calculation and review. And as a payer, obviously, we have some nice connections between the measures that we really want to see included in our value-based payment programs, and then designing some of the analytic tools to give providers real-time insight into using those systems. And then if any of you caught the panel right before this in the same track, my colleague, Dr. Deshawn Groves, gave a presentation on some of the work that we're doing around social determinants of health, screening, exchange, and referral, which is under development. And we're also working with projects like the Gravity Project, et cetera. So we're really trying to see how we're trying to push this as far as we can in terms of the scalability of our efforts around interoperability, and particularly with the SDOH work, we're talking very actively about the fact that that is an interoperability and governance first approach to ensure that there's the level of trust, such as Kina described in the beginning of her presentation. And there's also ongoing work under specialized registry submission. Okay, so I'm going to move a little bit more quickly to get to the good stuff around interoperability, but I don't want to skip over the point that, again, one of the reasons as a health services researcher who've done a lot of work on learning health systems with AHRQ, ONC, other federal agencies, was that I really felt that the tools at my disposal as a payer, particularly a public payer, to think about how we integrate the use of technology to truly improve care in a value-based model was just unparalleled. And so the Medicaid agencies, I really think, are a tremendous, again, learning opportunity for working with technology and across the agencies. So I always refer people to this model where we really talk about the land categories, which for those of you who aren't as familiar with the value-based purchasing world, they're really the framework that we think about in terms of increasing responsibility and shared accountability with health system and payers, as well as providers. And so I like to kind of talk about this as the salmon ladder of value-based purchasing, or improving with population health, because I like to remind folks that, these are big challenges, as Keena described, especially for primary care providers. They have to be thinking about the use of technology, how that use of technology aligns with quality measurement, and then they have to be talking about workflow changes to achieve those goals. So here's my sort of funny metaphor for the day, which is, I think, based on my experiences, that interoperability has much in common with multidimensional chess. And here you can see Spock and Bones, for those of you, I guess I'm aging myself, on Star Trek, playing this really funky game of chess that has all these different sort of component parts. But I'll talk about why I think this is an apt metaphor. And this is because, as ONC and other federal agencies have talked about, there really are multiple layers of interoperability. And in my experience, I have absolutely seen how you have to leverage them all to achieve the end result that we're talking about, not just in terms of sort of interoperability for interoperability's sake, but really improving the health system. So the key layers are technical, syntactic, semantic, and process and policy interoperability. And I have a reference here for a white paper that I worked on with several colleagues in a prior life that really sort of talks about and breaks down all the interoperability standards that are associated with these levels. So you can refer to that if you're interested. But what I want to emphasize, and I've really seen in my work, is that this process and policy layer really is that last mile that Keena was talking about. And so the only way, and you can see I've got arrows pointing to a couple of these little components on the board. And the way this works in multidimensional chess, and I'm no expert on multidimensional chess, but the reason I think this is a reasonable metaphor is because you can move these layers to kind of increase the height at which your pieces ascend. And I think that's really what the process and policy levers have to be used to do. So we've got payment models, federal rulemaking, local rulemaking, and a lot of practice transformation and workflow work. And I just genuinely believe in my work that we have to really align all those components. So here's my worked example. Our HIE policy board and the District of Columbia, for which I serve as chair, it's the mayor's policy board working on health information exchange. We've been talking for a while about the primary care providers' dissatisfaction with the degree to which they were receiving real-time information at the point of transitions of care, specifically acute care, discharge from acute care settings. And so, we've been having conversations about this issue for really years, going on 2 years. And we realized that in order to move this work forward, we were going to need to think about, again, those different dimensions that I described, and start moving the work with our health information exchange empirically in terms of assessing the data, but then also really working with all the partners who are contributing the data and finding the right set of carrots and sticks for them to move. So without going into this in detail, because you have the timeline here, over a relatively quick series of about 7 months, I think the timeline starts a little bit before this, we started working with a committee of stakeholders from across the district, and really started talking about how we could leverage some of the work that was happening already at the agency. And it was very timely, for example, that the CMS discharge rule was published just shortly after we started this work, which really we felt could be a very important lever to say, look, no longer do you have to be beholden to the idea that your discharge summary is a fixed set of data elements. You can actually send a partial discharge summary, but the key thing is to send it timely. And so we were able to do that work and work with our partners at the Health Information Exchange is to say, okay, what data could we actually send at the time of discharge to really facilitate that transactional care, leveraging, again, some of the standards and technologies that we have at our disposal. And so we have all this published publicly, and you're welcome to come, take a look at it if you're interested. But we basically said, look, CMS has given us flexibility to define what the transition of care elements are that are most useful for our providers. So we got a technical expert panel together, and they said, I'm sorry you can't see the distinction in colors here. Perhaps I can post another version. But they really identified 4 or 5 areas with discharge diagnosis, reason for visit, medication allergies, and discharge expectations. They said, we want to explore these empirically, really push in all of the different ways that we can to ensure that that information is exchanged timely. And then there will be a phase 2 of our recommendation. So in the interest of time, I will move along, but the bottom line is that working with this local technical expert panel and our committee, leveraging the national standards, both from ONC and rulemaking from CMS, we now have a local agreement, really sort of a scalable agreement about how we're going to proceed to implement interoperable real-time exchange of transition of care data elements. And we had to use, again, all of those different levers. So I think that's actually my last slide here. I think these are some backup slides in case anyone is interested in the structure that we have in place, sort of more of a marketplace-based approach to health information exchange that I'm happy to talk about. And then I have some slides. But again, the main thing that I wanted to emphasize is that really all of the parties have to work together to get us to a place where we can achieve interoperability. There's a role for everyone at the table, including our technology partners. And so I'm grateful again for the opportunity to present and share what we're doing, and look forward to feedback. So Ryan, back to you. Thanks.
Thank you so much. That was great. We've already got some awesome questions coming in. So I'm going to start with kind of melding one of my own with something that came through with respect to providers and technical challenges. So I know everyone here is kind of coming with a different perspective, and the work that I referenced earlier, I'll pull up a report in the chat for folks to look at the 360X program. But do ambulatory providers have what they need to be successful when we think about functional interoperability at scale? Aaron, I think that's a term I got from you and Kina and Grace. I think what I appreciate, Kina, about your perspective is jumping in and knowing there's more to do, but being willing to kind of work through it from that firsthand experience. And Grace, just the fact that you've been able to leverage the latest in technical innovation. So what I know, Aaron, you've seen in DC, and I'm sure is no different, for the others here, that there are often just very real technical challenges, even just to try and use direct. I mean, that's a definite issue in some cases in the FQHCs in DC. So what can be done to bridge those gaps, especially given some of the events of the last 5 months? Love to hear kind of each of you comment on that, and then we'll get to the next set of questions.
I mean,
Aaron, I think you're
chime in.
Oh, I was just going to say that I would love to hear Kina's thoughts on this.
Perfect.
Yeah.
We have really, as you noted, Ryan, we have really struggled with this issue, and especially for providers in independent practices, convincing them that, they were okay with implementing EHR. Some of them, unfortunately, were not always the best EHRs, especially for the longer arc of payment reform. But we've really struggled to articulate the value, particularly when they're so strapped, Kina, as you talked about. So I would love to know what suggestions and solutions you do there. We know they need a lot of technical assistance for sure.
Yeah, that's a really great question. I mean, we were a member of Direct Trust, participate in the Direct Trust bundle, and it's actually interesting because over the last like during COVID, we've actually specifically started an initiative to try to get all our providers using their direct messaging accounts that come with Elation, but that you're right, like off the bat, it's not the first thing that they go pursue. And in fact, they get concerned if it gets turned on and they don't know how to use it. I mean, we had one really interesting experience in a community where I think the local hospital had just turned on direct messaging, and but the providers weren't trained in it, so they all these messages were being received, but they didn't even know to look in their inbox or how to get there. And so I think the crux of that is a couple things. Like, one, education, right? It's like, here's what this is. Here's what this enables for you. We've had, I think there are aha moments that that we've seen providers have when it is working. And I think to your point, Erin, I think it starts with, let's just make it part of the system. So it's not something they have to add on, some like new workflow they have to learn. Like, they get incoming documents, incoming messages, incoming faxes. Like, there's all sorts of things they get incoming. So like, let's make this one of them. And then when they see it, let's make it easy for them to understand what it's saying and respond to it, right? And I think the biggest wows we've got are definitely discharge summaries, and then also immunization records through direct messaging. So yeah, I think it goes both ways. It's like, educate, inform, make sure they know that this is available, that they can live in a world where information is pushed to them electronically, and then simultaneously, let's make sure when they get that information back to the trust, right, that they understand it, they could use it, it's easy to receive, and they don't feel like they just have another burden on their shoulders. That's the last thing that they want.
And can I ask a question, Ryan? Following up on that. So, Kina, I'm curious, have you guys talked much about how to use secure text? Because that has been a really sticky wicket for us. I mean, we're seeing that increasingly, not only with providers, but also with beneficiaries. It's a text world. So I'd love to know if you're able to use, sort of find that link to secure text. And Ryan's going to laugh, I'm sure, asking that question.
And by secure text, you mean like secure text messaging, right?
Yes.
Yeah. Yeah, I mean, there's text messaging, right, which is what people are very accustomed to and enjoy doing, and is part of what patients are used to doing. And then there's secure text messaging, which then becomes a much more onerous thing to do. So it's like putting that adjective in front of it, and it changes the entire workflow and makes it a little harder to access. But I think, we've seen an explosion actually during COVID, to your point. Like, we've actually seen an explosion in asynchronous communication because the in-office visit isn't available, and because providers are now thinking really actively about how they engage their patients who can't come in to see them through the typical means. I think one of the big challenges actually with any of this asynchronous communication and secure text messaging included is like, how do you get that ultimately included into the record, right? And how do you make that, again, part of your workflows, so that next time when you see that patient, a typical primary care doc maybe will see 15 to 20 patients, but has to address something for maybe 3-4 times that in a given day. So they can't really keep everything straight. So being able to embed in their workflows so that they can reference that information back, I think is a major need and an enabler to get that adopted. But I agree that that's a modality that patients certainly want to engage in.
Maybe can I pitch in a little bit on how we use text messaging? I agree there's a difference between secure text messaging and regular text messaging. And in order to kind of protect the PHI information, we create different templates that the nurses and care coordinators can simply just click and text the patients. It almost like a nudging function. And then the patients can respond like one or two, like, do you need help, or do you you're okay. So if based on the patient's answers, we will spring different workflows to, if the patient needs help, we will put that into the workflow for the nurses to have the nurses call the patients proactively. So that's kind of, not totally sharing any PHI, but still have interactions with patients.
So you do it through standard text messaging?
Standard text messaging, yeah.
Arun, I think you're muted, my friend.
Thank you so much. Can you hear me?
Yeah.
Great.
Okay.
Okay. Great. Grace, I've got a quick question for you, if that's okay.
Sure.
Grace, you mentioned the Medicare patients not being tech savvy. How do you handle those patients that do not have internet access? Also, are you providing the devices free of charge, or are they being charged? Are they given a list and required to purchase their own devices? How does that all work? Just trying to get some insight into your business there.
Yeah, thank you so much. That's a great question. For the first question, we send the device. Basically, we have a gateway box that we put a 4G chips in it already. That's almost like a cell phone. Like I almost bring a cell phone together with the devices. So what the patient needs to do is just plug in the gateway box into their power outlet. That's all they need to do. Everything will be activated automatically. So the data will be, the gateway communicate with the peripheral blood pressure or thermometers through the Bluetooth protocols, and it will send the data to Lucidat Cloud through the cellular phone network. That's how we make it work for patients who are living in the remote area without Wi-Fi. So in terms of payments, the patients actually, they only need to pay 10% of a copay, the regular Medicare copay. Medicare pays month by month as long as the patient is enrolled into the remote patient monitoring program. The physicians can get between $110 to $190 per patient per month just by having the device at patient's home. There's nurses and care team monitor the data, respond to the notifications that we send out, and coordinate that work. So that's really the new, especially during and post-COVID, the new virtual care delivery model. Hope I answered that question.
Thank you so much. And I've got another question for Kina here. Kina, this is about the role of using direct secure messaging with acute partners that have optimized around referrals using direct and direct trust for data integration as well as open standards. Kina, would you like to talk about how that's working in your organization and with your organization?
Yeah, absolutely. And thanks for that question. The Direct Trust we're a member of Direct Trust, as I mentioned earlier, and our members and our providers do participate in sharing direct secure messaging with hospitals and health systems across the country. And so if there are instances of any of that not working effectively, I'd love to hear more about it. And so we're definitely big supporters of this. As I mentioned a little earlier, this has actually come on our radar to try to specifically drive adoption and amongst our community because of just kind of the tremendous benefits of direct messaging to our providers and getting the right information on a timely basis about their patients. And so I think that is, I would argue, one of the methods of exchanging data that has been most successful, and it's certainly taken some time. And what our experience is that providers definitely need to just learn about it, right? It sometimes is outside the scope of what they even think is possible. And so we've really, challenged ourselves to say, how do we make it easier for them to learn about, to know about, and then to experience the benefits of? And so we're definitely working hard on that path.
Thank you so much,
I would just
Tina.
add, I was just going to add, Erin, that we likewise think that Direct has been extraordinarily helpful. And I think, we're at a place right now. And one thing that I hear as a thread between all of the presenters is let's use the tools that we've got. And Direct is very much one of them. And, it's not to say there aren't challenges, but a lot of them, as Keena said, really are workflow challenges. So, for example, we worked with a large multi-specialty practice group who said they had just gotten to a place where they were getting a lot of spam in their Direct, mailbox. And so there's probably some relative ways we can work around that that would still make electronic exchange viable for them. So, we just have to really be thinking, again, I think about use those tools and create the right set of incentives and requirements for providers because they're so incredibly busy. So we try to have empathy.
Thank you, Erin. For those who, I just want to make a plug for those who maybe missed my introductory comments, that Direct Trust is a very important partner to ONC, and as such, they are a featured exhibitor in our exhibit hall, along with the 360X referral program. Unfortunately, we were hoping to have someone from NetSmart be with us, but we pulled this event together quickly, but we made sure that the resources are available in the exhibit hall for those to see on both days and not just in a 1 hour snippet. You can put down any information into your briefcase and also get back to us with any questions. And we'll be happy to make that information available to those that are more interested in or aren't familiar. And Keena, both of you, all of you, thanks for how you answered the questions so far. Next, I want to cover a question about alert fatigue. I know, I think at least Grace in your case, you talked about how your experience, your personal experience, kind of coupled with your professional observations, helped you to bring in things like chatbots and the latest in technology that throughout the sessions this week, we've talked about how lessons from use of API and FHIR and other industries have helped inform where we're going in healthcare. So speak to that question or topic of alert fatigue and just the inundation of information and not always knowing and having best intentions, I think is something we also hear a lot about. Like some people, some things work really well for some and not for others. And it's not because it's anyone's fault or anyone's like right or wrong all the time. But, if you operate on people are trying to do the best they can and use technology to kind of bridge those gaps. So maybe Grace can start with that one and then others can chime in.
Sure. That's such a great question. And that's actually exactly one of the key technical challenges we spend a long time trying to, find the best solution for. We at the very beginning, we got so much alerts from the devices. Is not a joke. Depends on how many patients the care team has enrolled. We could get within an hour, more than 200 alerts, blood pressure too high, blood pressure too low, heartbeat too high. It's there are just really a lot of information. So it's impossible really for a human to sit over there to man the data. So we spend a lot of time building algorithms to combine this. For example, we used basically algorithm to study the frequency of the alerts. First, we look at the difference, right? It is within certain range of the threshold, and secondly, the frequencies. So if it is continuously 3 times, we will escalate to a certain level. So this is where we build algorithms to triage the patients to the right team. So even within the team, there are different levels of, the first end of nurses, and then we escalate that again through our workflow bot that we can triage to the right people. So this is a very good question. It is a very tough challenges to work on. Yeah. It's a work in progress, I would say, but we definitely consider that, yeah, we have algorithm built in and a workflow built in.
I could chime in there as well. I think one, alert fatigue, definitely a very real thing. I think that, two thoughts that come to mind. The first is obviously technology and design can play a really big role. I mean, I think one would be surprised at the sort of low-hanging fruit that's available there. It's like, hey, an alert comes into the EHR, literally like right next to the alert that maybe, blood pressure needs to be checked or some sort of gap in care is identified. There's right next to that a note that says that the blood pressure was checked or that the gap has been resolved. And so there's an element of like, hey, low-hanging fruit, information's there. Let's reconcile it. Let's not put that in front of the doctor. But yeah, taking that a step further, I think that as information proliferates, right, as we design these pipes that move the data around, I think AI and algorithms can have a huge impact on really saying, what is the important information that needs to come through? What needs like a human or an expert assessment on determining course of action and making that really what takes up the time and attention of the doctor. I think the second thing that this makes me think of as well is just the role of primary care and the future of primary care. I think that more and more is being encapsulated within primary care, and really primary care is evolving from, a primary care physician to, primary care team. And how does that team collaborate to be able to process like more and more data that's coming through and really encapsulate more of that overarching kind of goal of primary care. And this is inclusive of, hey, here are these things that are happening. We're now understanding or having visibility into a lot more, but how do we still then break that down into what's important to focus on and what should we actually act on?
Perfect.
My perspective, I would just add, again, alert fatigue, very important issue. We may not be able to go into today, but we should also kind of remember that as all the consumer technologies develop, we're going to deal with alert fatigue for individuals as well. Grace, one of the things I really liked in your description of your text message approach is that, those behavioral nudges are intended to make somebody feel cared about, not overburdened. And obviously, I'm sure you have to titrate those as well. But it's really the technology working in combination with providers and with beneficiaries or patients in this case that we know is the secret sauce, right? So that's simply to say, I think we all know that, but just not forgetting the patient in that equation, because the big concept that I know everyone's really struggling with is, how do you define real time for a particular intervention or a condition? And so with respect to the example that I presented about discharge summaries, again, we were seeing so many providers who were saying that they did not feel that they were receiving actionable information about, an acute care visit, timely to act upon it, right? And so we would see, for example, so when we did the empirical analysis, about 40 to 50% of discharge summaries were received at the time of discharge or within the next 24 to 48 hours. But there was a long tail of that distribution that was showing those summaries were not received until the last day they were required to be shared, which was 30 days. And I can't tell you how much that distribution, showing that distribution to our clinical leaders in the community, made them say, okay, now we get it. Now we get it. That is not sufficiently real time. And so it's making some, but then, again, getting clarity, those 4 data elements that I showed, and the notion that they could be exchanged real time via the HIE, that's what's really changing people's perspective. Again, using those tools that we have leveraging the conversations among, clinical and technical leaders to say, what do you really need and how can we get that to you in a way that would be timely so you can intervene appropriately for your patient. So it's, again, bringing those components together. And I think then the last big piece for us is figuring out how do we bring the patient into that discussion to make this, as effective as possible.
Thanks, Erin. I have a question for you. You touched on the 17 different EHRs, and I just wondered if you could share any kind of insights specific to the use of the HIE and how that having that infrastructure in place has helped, if it has helped in the last few months, and how those tools and those core functionalities, just having those inherent in place as you build on those, on that foundation. If you could speak to that a little bit, that'd be great.
Yeah, so I mean, the current pandemic, the COVID-19 pandemic, is the clearest example of the ways that health information exchange has been highly beneficial that I can, certainly think of in the near in the near history, but it's just a really compelling example. So, as the federal public health emergency was established, because we already had existing connections and mostly, sort of direct integration, certainly for the hospitals, but actually for a lot of the larger, multi-specialty practices or even the QHCs, we had that integration to the HIE directly in place, which I think, as I mentioned, or maybe it's one of my backup slides, connects over 9,500 providers within the district, which is, the vast majority of folks. We were able then to turn very quickly, work with our public health authority, DC Health, establish an administrative order that said that now COVID-19 was a reportable condition, and mandated the sharing of all of that data, not just obviously from the public health laboratory, but also from the and from the large commercial labs with the HIE. And what that did extraordinarily quickly, we were able to implement those changes within 2.5 weeks. And what it meant was that instead of the public health department having to worry about making sure that those notifications got sent back out, you could actually use the federated or distributed network to make sure that providers had that information. And we have a couple of, if folks are interested, you can go online. There are a couple of webinars where providers talk about the use of the system. But it completely changed their workflow, because now they can rely on the fact that if they, did huddles in the morning, they would have the most recent lab results, and they could immediately follow up with anybody who, who had either called in or, had a positive or negative test result to check up on them. And I think those are the types of things that increasingly we'll be able to do with, a large scale interoperable system that's for which the health information exchange is the backbone. And I should say that a lot of that is FHIR enabled.
Thank you so much, Erin. Thank you. Okay, so I've got a couple more questions I'd like to ask everyone here. But before I ask that question, with about 20 minutes left on this panel, I want to ask all of you to have a question. If you could ask one question of each other, what question would that be? So I'm going to tee up a question that you can ask each other. But before we go there, I want to know what we can all do to enhance communication for both baseline health information, but also SDOH data. What can we do to enhance that communication loop for both baseline health information, but also SDOH data? Would somebody like to jump in there?
Maybe I can start?
You betcha, Grace. Thank you.
Okay, so because that's exactly where our next steps are. In terms of SDOH communication, so far what we have done a tremendous amount of work is to analyze the EHR data with the care management conversation. So we are able to identify patients' social determinants of needs. Now, the next step is how to match these needs with the resources. We know there are like 211.org or Healthify. There are they curated a lot of information about community resources who can help with financial, food shortage, and loneliness. There are many, many resources. So we are hoping to find a better way to connect with those resources because we have the needs, we have the demands. How can we connect them seamlessly, and help the care team identify those resources in real time and take actions quickly? Because that's kind of what we would love to have. Hope I answered your question.
Absolutely. Thank you so much. Okay, and I've just been notified that we actually only have 5 more minutes left on this call. We're not going till 4:45. We're ending at 4:30. So let's go around the room with these. If Kina or Aaron, would you like to answer that question?
No.
I think the one thing, just to add a short comment to it, because I know we're short on time, but I think the one thing is to make it basically easier from likely a standards perspective, but a specific standards perspective to be able to support this exchange of data for a platform like ours, right? So there's a number of cases in which we have to go basically state by state and sort out how exactly data is going to get exchanged with different entities. And that's just time consuming and hard when the intent is there. So it's a coordination challenge, but I would certainly push on that dimension.
Thank you.
And I have
Aaron?
very specific federal actions. So one is, as a lot of folks know, under the CARES Act, there's a new provision to really align consent for particularly 42 CFR, the substance use disorder data. And that is just so essential. I mean, we have created a bifurcated system, and I think all the systems and potential technologies we've discussed really is going to be dependent on better integrating care and information folks who have substance use disorder, which is highly prevalent in the United States. So I'm really looking forward to that federal action to resolve and align information sharing across these systems of care, and I think it's just essential. And the second has to do with something, Kina, that you mentioned a little bit earlier, which was the challenges, and I think you even said sort of battle scars of integrating data from various sources. And I think we just still have not seen enough investment in really understanding and developing good data quality frameworks that help us validate transactional data. And I fear if we don't do that work, I mean, it's great people to exchange the data, but if folks don't know what it means and how to interpret it, or have questions about the data validity, I think we're just going to have a much tougher time as we move forward. So I would welcome support, assistance, partnership from ONC to really be thinking about those issues, because it's just, it's going to be critical to future uses of particularly integrated clinical and claims data.
Well, thank you all so much. Before we close out, thank you all. Anyone that's still here with us, thank you for being here. Refer back to all the resources on this platform. Thanks to all that helped put it together. The ONC CARES Act Final Rule website, the exhibit hall, healthit.gov. Please be in touch with us. Thank you so much for all you're doing in healthcare to advance interoperability. And have a great night. Thanks so much again.
Thank you.
Bye, everybody. Thanks, guys.
Bye.
Bye.
Ladies and gents.